Hi everyone. In this video, we will be discussing about nephritic and nephrotic syndrome. So first, we are discussing nephritic syndrome. In the nephritic syndrome, we have infection-associated glomerulonephritis, also known as post-infectious glomerulonephritis, and it is basically type 3 hypersensitivity reaction associated with hypocomplementemia. And in the children, we will be comparing in children and adults. In the children, it is caused by group A streptococcus, seen 2 to 4 weeks after the pharyngeal or skin infection, and has positive strep serology and usually resolves spontaneously. While in adults, it is related to group A streptococcus but can also be caused by staphylococcus and seen during infection. An infection site is variable but usually not upper respiratory tract. Here it was occurring after the infection, but here it is occurring along with the infection, and it must be identified on culture. No serology will be positive. Okay, acutely serology will not be positive and may progress to renal insufficiency. Then in the light microscopy, in every case, we will be remembering the light microscopy, the immunofluorescence, and the electron microscopy finding. In the light microscopy, glomeruli will be enlarged and hypercellular, and on immunofluorescence, there will be granular, starry sky appearance, lumpy, bumpy appearance due to IgG, IgM, and C3 deposition along the GBM and mesenchyme. And on electron microscopy, there will be subepithelial deposits. So let's see the image. See, this is a image. This is showing hypercellular glomerulus and infiltration, inflammation. It is related to post-streptococcal glomerulonephritis. And this is the immunofluorescence showing the lumpy, bumpy or starry sky appearance. Then next entity we have is of IgA nephropathy. IgA nephropathy, also known as Buerger's disease, linked with CD71. It is episodic hematuria that usually occurs concurrently with respiratory or GI tract infections. Respiratory or GI tract infection and is related to Schonlein purpura. On the light microscopy, mesangial proliferation will be there, not the glomerular but mesangial proliferation. On immunofluorescence, mesangium deposits will be there, and on electron microscopy, mesangial deposits. So all the things in the IgA nephropathy will be occurring in the mesangium. On light microscopy, on immunofluorescence, and electron microscopy. Then we have rapidly progressive glomerulonephritis. Rapidly progressive is also known as crescentic glomerulonephritis, and it is known for rapid deterioration within days to weeks. Crescent moon shaped on light microscopy, crescent moon shaped will be present, and crescent consists of what? Fibrin, plasma proteins, C3b, parietal cells, monocyte macrophages. Monocyte macrophages, the eating cells, then the parietal cells, and plasma protein and fibrin. And they are of three types: linear, negative, or posseimmune, and granular. Let's read one other thing about the RPGN. See, from here we are reading types of RPGN. Type 1 is good pasture syndrome, okay, related to the anti-GBM antibody and immunofluorescence. As it is related to basement membrane antibodies, so immunofluorescence will be linear. And in type 2, there are immune complex deposits. Immune complex deposits can be there in post-infectious or non-infectious cases. In post-infectious come PSGN, bacterial endocarditis, shunt nephritis. Non-infectious SLE, Hinosh-Schonlein, cryoglobulinemia, and solid tumors. And primary renal disease, membranoproliferative, and IgA nephropathy. Basically, immune complexes can be due to infections, due to tumors, SLE, and due to other renal diseases, and the immunofluorescence will be granular here. And in type 3 is known as posseimmune, where there will be no immune deposits. And it is linked with the cytoplasmic antibodies, that is Wagner's granulomatosis or granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, also known as Schuch-Strauss, and microscopic polyangiitis. Both eosinophilic and microscopic polyangiitis that are linked with the PNK or MPO, myeloperoxidase. But the Wagner's is linked with the CNK, anti-cytoplasmic antibody, and it is linked to the proteinase 3. Wagner's is CNK proteinase 3. And PNK is, see, in the PNK, what we need to remember, PNK is not related with proteinase. P for P is not there. Here, if the PNK is there, then there is MPO. And rapidly proliferative, grossly enlarged kidneys with the petechial hemorrhages will be present, also known as flea-bitten kidney. And fibrin strands between the crescent. On microscopic examination, fibrin strands, crescents will be there. In posseimmune case, there will be necrosis, segmental glomerulonecrosis. And on electron microscopy, ruptures in the GBM immune complex deposition in type 2, subepithelial immune complex. Okay, in the PSGN also subepithelial were there, and in the rapidly proliferative also we have subepithelial deposits. Then coming back to the same page, so this was left linear immunofluorescence in type 1 due to antibodies to GBM and alveolar basement membrane, also known as good pasture, will result in GBM due to GBM hematuria and due to alveolar basement membrane hemopsis. It is a type 2 antibody linked reaction and treatment is plasmapheresis. Then is granular. Granular is due to PSGN or DPGN in which immune complexes were there. Then is negative or posseimmune in the Wagner's, Chugh-Strauss and the microscopic polyangiitis. Then we have diffuse proliferative. Diffuse proliferation, think of the SLE. Okay. Diffuse proliferative and MPGN often present as nephrotic syndrome and nephritic syndrome concurrently. Means in diffuse proliferation and membranous proliferation, whether only membrane is proliferating or diffusely it is proliferating, in both the cases there will be both nephrotic and nephritic syndrome. And on light microscopy we will be seeing the wire looping of the capillaries. Upon immunofluorescence, granular deposits will be there, and on electron microscopy, subendothelial, sometimes subepithelial, or intramembranous. Means all the three types of deposits can be present in diffuse proliferative. Now let's see the images. See, this is the image showing the crescent. Then this image is of wire looping of the capillaries. Wire looping of the capillaries present in the diffuse proliferative. This we will discussing afterwards. Then we come to Alport syndrome. Alport syndrome is mutation in type 4 collagen. As we know, the type 4 collagen is present in glomerular basement membrane. So type 4 collagen mutation, irregular thinning and thickening and splitting of glomerular basement membrane, and it is X-linked dominant. Alport is dominant. Okay. And in this we have the mnemonic can't see, that is eye problems will be there, can't pee, kidney problems will be there, and can't hear a bee, hearing problems will be there. And on electron microscopy we will be having basket weave appearance due to irregular thickening. Now let's read another thing about the Alports. Alports is mutation in collagen 4, col4, and there are three types, col4 A3 and A4 that are autosomal, and col4 A5. 5 is for X-linked dominant. Then triad, can't see, can't hear, and can't pee. Glomerulonephritis, hematuria, earliest most common presenting feature, mild proteinuria. Then in deafness, sensory neural hearing deafness, and most common extrarenal abnormality is sensorineural hearing loss, and it is asymmetric. In the ocular abnormalities, we have related to the retina, we have retinopathy. Then related to the lens, we have cataract, and to the cornea, anterior lenticonus, and corneal erosion and opacities. And the treatment is control of systemic hypertension and use of ACE inhibitors to slow the renal disease progression and ultimately renal transplantation. Now, coming back to this page, now another entity is membranoproliferative. In membranoproliferative, COPE presents with the nephrotic and nephritic. This we have already studied DPGN and MPGN. Both the entities will be present. Now it is of two types, type 1 and type 2. Type 1 is secondary to Hep B, C, or maybe idiopathic. And in type 1, we will be having subendothelial deposits. And in the type 2, endothelial is first coming here. Before what we have read, we only had epithelial deposits. And in type 2, it is associated with C3 nephritic factor and decreased C3 levels. Decreased C3 levels are there because C3 convertase is stabilized. Then intramembranous deposits. In the type 2, we will be having intramembranous deposits, also called dense deposits, means in the membrane densely deposited material is there. Okay, and both the types will have mesangial ingrowth, GBM splitting, and due to that, the tram track appearance. Tram track appearance is in membranoproliferative. Okay, now we read more about membranous. This was about membranous. About membranoproliferative, it is that much only. Okay. Membranoproliferative is linked with the SLE, CLL, Hep B, and Hep C. Then we have minimal change disease. Now we are coming to nephrotic syndromes. Nephrotic syndrome, massive proteinuria more than 3.5 gram per day. Minimal change disease, it is the most common cause of nephrotic syndrome in children and peak is in 6 to 8 years. Often primary, that is idiopathic, and can be due to infection, immunization, immune stimulus, and rarely due to lymphoma. What can cause it? The four eyes. Idiopathic infection, immunization, and immune stimulus, and rarely secondary to lymphoma, excellent response to glucocorticoids. The minimal change disease is meant for glucocorticoids. It has excellent response both in adults and child. Then light microscopy, minimal change means normal glomeruli will be there, lipid may be seen. Okay, and immunofluorescence is negative. And electron microscopy, we can see effacement of the podocyte foot processes. Another thing is we can also see the Maltese cross appearance in the nephrotic syndrome. Then we have focal segmental glomerulosclerosis, means focally, means some portions of the glomeruli involved, can be primary, idiopathic, or secondary to conditions like HIV, infection, heroin use, obesity, interferon treatment, sickle cell disease, and congenital malformations. The ones which were linked with the membranoproliferative were SLE, CLL, Hep B, Hep C. And here we have the from H, we have the HIV infection and heroin use, then is opacity, and then is sickle cell disease, congenital malformation, interferon treatments. On the and it can progress to CKD, segmental sclerosis, and hyalinosis. Immunofluorescence is often negative, but may be positive for focal deposits and effacement of food processes. So, in the immunofluorescence and electron microscopy, it is similar to minimal change disease, but the difference is it is does not respond to steroids, and on light microscopic changes were visible. So minimal change to some changes, focal changes, then membranous changes. Membranous change is also called membranous glomerulonephritis. It is primary, that is due to antibodies to phospholipase A2, or secondary to drugs. Drugs are NSAIDs, penicillamine, gold, and infections, HBV, HCV, syphilis also were present in the membranoproliferative and SLE or solid tumors, and increased risk of thromboembolism, DVT, and renal vein thrombosis. And this is the most common nephropathy associated with the malignancy. Then may progress to CKD. And on light microscopy, diffuse capillary and GBM thickening, immunofluorescence will be granular, and electron microscopy will show spike and dome subepithelial deposits. Here again comes the subepithelial deposits. First, we have studied the subepithelial deposits in the PSGN. Then we have studied the subepithelial deposits in the RPGN. And then we in the first we studied in the PSGN, then we studied in the DPGN, and now we are studying here in the membranous. Spike and dome appearance. Okay, spikes and domes are there in the membranes. Then is myeloidosis. Myeloidosis, AL myeloid, AA myeloid, or prolonged dialysis. And on the light microscopy, Congo red stain shows apple green birefringence under the polarized light. Then we have diabetic glomerulopathy. In the diabetic glomerulopathy, what basically occurs is hyperfiltration, and hyperfiltration results in the hypertrophy and glomerular scarring that leads to glomerulosclerosis. So sclerotic nodules will be there, and mesangial expansion, GBM thickening, eosinophilic nodular glomerulosclerosis, sclerotic nodules, mesangium is expanding and GBM is thickening, and this is pass positive. The images we will be discussing. First, we read what is given here. Nodular glomerulosclerosis lie within mesangial core surrounded by peripheral capillary loop, mesangiolisis, fraying of the mesangial or capillary lumen interface, capillary microaneurysm. So basically, glomerulosclerosis will be there, and the capillaries are weakening. So microaneurysms will be there. And all lobules are not covered by nodular lesions, uninvolved lobules and glomeruli. See, where the nodules are not occurring, there occurs the mesangial sclerosis. And basically, hyaline material is deposited in the capillary loops, then it is called fibrin caps. In the Bowman's capsule region, capsular drops, and both the efferent and efferent arterioles. If the hyaline material is deposited in arteries, then it leads to renal ischemia, tubular atrophy, interstitial fibrosis, and contraction. Basically, blood supply to all the region is cut, so the contraction and fibrosis occurs. And also the renal atherosclerosis, arteriosclerosis, pyelonephritis, necrotizing papillitis. Means infections are likely to occur. That is about the diabetic glomerulopathy, and the classical name given to it is Kimmelstein-Wilson lesion. Kimmelstein-Wilson lesions. Then here membranous we have read spike and dome pattern. Then all this we have read that it may be due to drugs, due to other conditions, and other group of condition which can be related with membranous are primary biliary cirrhosis, dermatitis herpetiformis, bullous pemphigoid, then is myasthenia gravis, Hashimoto thyroiditis, Sjogren's disease. Basically, all the autoimmune conditions can be related to membranous glomerulonephritis, and they can reoccur who undergo transplant. Male gender, old age, hypertension, persistence of proteinuria is worse prognosis. Concurrent sclerosis is also poor prognosis. So let's discuss the images which were left. These images we have studied. Now let's see this image. The A image is related to effacement of food processes. Okay. Then the next image. Next image is related to the segmental sclerosis. See, this region sclerosis occurs, but this region is normal. And then this is membranous nephropathy. Diffuse sclerosis has occurred, and spike and dome pattern will be there. Spikes and domes in the membranes. Then this is image of the Kimmelstein-Wilson lesion. Nodular hyaline material is deposited. Then now let's see the one thing which was left is this one, that which are subepithelial, which are subendothelial, which are membranous, and which are mesangial. First we read post-streptococcal, then rapidly progressive or crescentric, and membranous. These have the Subepithelial deposits. Subendothelial are deposits in the lupus nephritis, that is DPGN, and in the membranoproliferative type 1. In the membranoproliferative type 2, it is membranous deposits. And in the mesangial, we have IgA nephropathy in Auschwitz. Then now at the last, we will be again revising the classical names as it is more likely to be asked. So what is the classical names of the appearances? In the infection associated or PSGN, starry sky, lumpy bumpy. Okay. In the children after the pharyngitis, what is occurring? Starry sky or lumpy bumpy. Then in the rapidly progressive, crescents will be formed. In the SLE, diffuse proliferation, wire looping will be there. Then in the Alport's, basket weave. And in the membranoproliferative, if proliferation of membrane is occurring, then dense deposit and tram track. Okay, membrane is proliferating, then the dense deposits are going on the tram tracks. And if there is minimal change, nothing is there, then classical is spike and dome. Spike and dome in membranous and dense deposit on tram track was in membranoproliferative. Kimmelstein-Wilson lesion. So that were all the important points which we need to remember about the nephrotic and nephritic syndrome. I hope that it will be useful for you. If you like my video, please do subscribe my channel. Thank you.